I forgot to say. Okay, now I will talk about the gestational trophoblastic neoplasia. So it contain of by the definition is a presented with the woman with presented with the plateau or increasing beta C level despite complete evacuation. Characteristic is aggressive invasion of endometrium and myometrium by trophoblastic cells. Right. The incidence is about 15 to 19 over the 1,000 female. Okay. So in terms of GTN, in the GTN, so by the UK guideline, it say how we say it's GTN or persistent trophoblastic disease. In terms of UK guideline, so first is a plateau or rising of HCG concentration after evacuation. Means there is a plateau or a rising HCG concentration after evacuation. Plateau is persistent after 3 to 4 consecutive of serum beta HCG. Okay, in concentration of 10 to increase more than at least 10% lah. Okay. Number 2 is the beta HCG remain elevated after 6 months evacuation, even though it's still showing decreasing trends. Okay. HPE bad as a choriocarcinoma or any placental trophoblastic disease or epithelial trophoblastic disease. Heavy vaginal bleeding or evidence of GIT or intraperitoneal hemorrhage or any metastasis. Okay. And then serum beta HCG more than 20,000 in term of 4 weeks after evacuation. 20,000 after 4 weeks, still 20,000. Okay. In term of GTN, we have classified into we have choriocarcinoma, we have persistent trophoblastic disease, we have invasive mole, and then we have placental-site trophoblastic tumor, epithelial trophoblastic tumor. Okay. Alright. In the characteristic of the most common GTN is an invasive mole. So mean the whole chorionic release accompanied excessive or trophoblastic cells overgrow or invade and penetrate the myometrium. Okay. So alright, about the gestational choriocarcinoma, the incident is very rare but it's a common GTN. Incident is about 1 in 30,000 non-molar pregnant women initially. So it's extremely malignant. Okay. So it contains sheet of anaplastic, trophoblastic, and prominent necrosis and hemorrhage vascular invasion. Initially, it invade the endometrium and then myometrium, then to develop early blood-borne system metastasis lah, means hemorrhagic mets. Right. So most developed during post-evacuation. 2/3 of follow the term pregnancy, 1/3 of the choriocarcinoma is because of after miscarriage or termination of pregnancy. Okay, the symptom patient may presented with the PV bleeding. This is the most common symptoms. Okay, and then delay because it's a subtle sign of symptoms. Intramenstrual bleeding and beta HCG level is and then you can still positive lah. Alright, and then increase the mortality for women following the term pregnancy, that about 10 to 50%. Characteristic is a biphasic architecture and recapitulating in cytotomobasil-like cells, multinuclear and premorphic cytotomoblast, means all 3 cells present, means intermediate present, cytotomoblast present, and cytotomoblast present also in the HPE finding. Compare with the but absent of villi is absent. Okay. Compare with the placental-site trophoblastic tumor, is an intermediate trophoblastic is present of intermediate trophoblastic cell at the placenta site tumor. It's a very rare GTN variant and a unique behavior. Most common present after post-term gestational delivery. Compared to choriocarcinoma, 2/3 only present as post-term. Another 1/3 is a present of miscarriage or termination of pregnancy. Okay. So patient may present with irregular provisional bleeding almost 1 month or up to 1 year after antecedent the pregnancy. Infiltrate only within the uterus, indisseminate late is the delay, very late. It produce low beta ICG because it didn't contain any syncytial trophoblast or cytotrophoblast. It just contain. Okay, so when it separate, it pattern might mirror like gestational choriocarcinoma. At the same time, it produce placenta-like Trojan, and metastasis is about 16 to 54%. Okay. Initial it spread as lymphatic spread more common, and then para-aortic. If present of para-aortic lymph node, is a poor prognosis mean. Okay, by microscopically, in the absence of villi with the proliferation of intermediate trophoblastic cell, fewer of hemorrhagic lesion. So hysterectomy is the primary treatment actually, because it's a less chemosensitive. Okay. If patient refuse for surgical intervention, IMA-co regime, we can offer her. About the epithelial trophoblastic tumor, is a rare trophoblastic tumor, but it developed from transformation of chorionic types to intermediate trophoblastic cells. It's a chorionic. Okay. So in resemble of a PSCT, but cells are smaller and display less nuclear pleomorphism. Grows in a nodular fusion and rather the infiltrative pattern. Behave like benign and then show like malignant. Okay, 50% only show like malignant. 51.5. Right, management is hysterectomy because it's a less chemosensitive. Okay. Alright, in the term of metastasis GTN, at the site lung is almost 80% lungs. Okay, mortality rate is about 100% actually. Vagina met is about 5 to 16%. Brain about 10% only. Pelvic about 4 to 7%. Liver about 1 to 4%. The presence of liver met is a poor prognosis, and brain met also poor prognosis. Okay, most common is a choriocarcinoma. And then non-metastatic GTN like invasive mole is the most common, and then 12% is a complete mole, 46% partial mole. EDTM PCT is very rare. It's a good prognosis as a non-pregnancy. In terms of staging, GTN is a highly vascular, is a common cause uterus vascular malformation up to 50%. Alright, in the fecal anatomy staging, first stage is confined to uterus only, right? Second stage is extend outside of the uterus but limited to genital structure only, means in only genital structure only. Third stage is the GTN extend to lung or with or without non-genital tract involvement, means lung first, stage 3. 4 is all other metastases. Okay. Based on WHO prognosis scoring, is important to determine whether we to start single agent or multi-agent in the chemotherapy. Okay, so first the risk prognosis scoring is depend on age, antecedent pregnancy, means in the current pregnancy, either we diagnosed during the mula pregnancy during the miscarriage, term or post delivery. Okay, preterm beta ICG, and the largest tumors, the tumor size. Okay, site of meds, number of med, previous fail of chemotherapy drugs. If the score less than 6 or equal to 6, 95% survival rate over the, and 7% survival rate over the 5 years duration. Right, high risk is more than 7. Okay, overall survival rate is about 79%, is equal to 80%. Right. Okay. 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 In term of treatment, GTI is a chemosensitive, especially in choriocarcinoma. So the low risk persistent ovarian also is a chemosensitive. Okay, low risk GTN by prognosis score we suggest single agent MDX. Okay, it's a completely response about 99%. Okay, and then prospective cohort study shows it's a dosage we given if 50 millimeter body square and body surface area. Okay, continue the chemotherapy till the beta ICG was normalized. Okay, then after that 2 to 3 additional chemotherapy after beta ICG normalized. Okay, folinic acid and folic acid is a antidote for the MTX to less the risk, systemic risk. The side effect is stomatitis, serosal symptom, pleuritis, pancreatitis, and peritonitis. Okay. In case of resistant of MTX or sensitive of MTX, we can choose the second chemotherapy, dactinomycin or actinomycin D. Side effect is alopecia only, and due to less use because due to toxicity is concerned because it's a high toxicity compared to MTX. Complete response about 79%. In the high risk case, the survival rate is 86 to 92% after chemo, and then 5% is of GTN and relapse about 7 to 10%. Multiple chemotherapy agent like regime IMA or IMACO. Okay, IMA is content of etoposide, methotrexate, and actinomycin D. Plus CO is a cyclophosphamide and vincristine, or we call oncovixin. Okay, if patient are resistant, we may add up in the platinum base or surgical incision and or excision. Okay. Side effect of IMACO you must bear in your mind is mucositis, pleuritis, alopecia, liver derangement, and myelosuppression, and Christian and neuropathy. In the brain, may present of neurological symptoms, and multimodality treatment is offer. First, surgical excision at the brain or craniotomy. Number 2 is a chemo radiation therapy. It's a poorest prognosis, survival rate about 10% only. Okay, in the term of PSCT or ATT, this is for me is the first line actually. Ovarian preservation is a safe, and okay, local excision and hysteroscopy is a key if patient keen for fertility preservation. Alright, if resistant in patient PSCT or ATT, IMACO is a chemotherapy drug of choice lah. 90% survival rate over the 10 years. Okay, if a chemotherapy, how we follow up the chemotherapy? Okay, how we follow up by it recurrence occur within 1 year. So in terms of management, we monitor is lifelong. No recommendation follow up. Best follow up is offer. During treatment, we monitor the urine ICG and serum beta ICG. After treatment stop, weekly off to for 6 weeks, up to 6 weeks. Jangan kacau. So in terms of treatment, so we monitor the urine ICG, serum ICG twice weekly. Okay. After stop the treatment, we may monitor weekly up to 6 weeks. This is by UK punya regime. After 6 weeks, we just monitor serum ECG. So during the first year of follow-ups, the regimes is a 2-6 monthly. They did the serum beta ECG, and then after 2-6 months, after 7 months to 12 months, they did the urine ECG only 2 weekly, right?
And then second year they did a monthly urine ECG. Third year is they did 2 monthly, 3 monthly, after that 4 monthly, up to 6 monthly after more than 6 years. Is advised to avoid any pregnancy. So contraception is advised for 12 years. 12 months, sorry, 12 years. 12 months after the complete the treatment. Okay. In terms of fertility, so they said after the treatment, the questionnaire study says 70% is a reduce the sexual desire, and 42% is a dyspareunia, and 45% is a lubrication of problems, and then about 53% is a relationship. There is a problem with the relationship. Okay. However, the overall fertility rate is up to 80%. Live birth is about 70%. Term is term 71%, and preterm birth is about 5%. Stillbirth is 1.3%, and miscarriage 14%, and congenital malformation is 1.3%. If conceived less than 6 months, the risk is higher compared than 12 months. So after pregnancy, is advised to is recommended to do the beta ECG 6 weeks and